Hello and welcome to this webinar hosted by True Rx Health Strategists. We are a pharmacy-owned, people-first PBM that empowers employers and patients to thrive with forward-thinking, personalized solutions that change the world of healthcare. I know change the world of healthcare sounds really bold and ambitious, but it's really simple for True Rx. We are here to help take care of our employers and our patients. We want to help make medications more affordable. We want to take great care of patients. That's really at the heart and soul of our business. And at the end of the day, we want people to be healthier because we know that's the only way people will thrive. And that's the only way businesses will be able to afford their healthcare costs. I'm Adrienne Laborowit. I'm our Chief Strategy Officer. Our goal with these webinars is to share industry knowledge with you so that you can continue to bring value to your clients, or if you're an employer joining us, you can continue to learn about different solutions in the pharmacy space and in really the healthcare space to help control your costs and take care of the employees that make your business run and the people that you care about. We call these true conversations. That's intentional. We want this to be a conversation. This is not going to be a big slideshow where we have, lots of slides. This is a conversation between our panelists, but we invite you to join us in the conversation as well. So please feel free to put in your questions. We have had great success with questions and people who have been very engaged in these webinars. So we invite you to be part of the conversation today. Today's topic is all about maximizing infusion treatment savings. And this is often not historically or traditionally talked about in the pharmacy space. This is one of our innovative solutions that we provide to our employers. It's really one of the fastest growing cost drivers for self-funded employees. Your infusion costs are really what is helping to drive up your healthcare costs. So we have a solution around that today and providing significant savings for our employers so that you can help control your pharmacy costs on the medical side. You'll leave with real-world strategies and an inside look at our True Codes program, which is delivering an average of 40 savings per claim. With that, I would love to introduce you to our panel today. We have such a great panel that I'm very excited about. Jacob Nair, who is our Director of Clinical Strategy at True Rx. He is a pharmacist and he's focused on optimizing our pharmacy benefit strategies. If you are a broker partner of ours or a client of ours, you've probably seen Jacob around. He does a fantastic job being a consultant for all of you. We also have Anna Olson-Kreger. She's our senior nurse navigator. She comes to us with over 20 years of infusion experience. So when we talk about having nurse navigators as part of our team, these are people who have been patient first for many years, for decades. And so the patient is always first in their mind when they're looking at savings. It's not just about providing savings, but it's also about taking care of that patient. So we're so happy to have Anna join us. And what I'm really proud of today is we have Scott Ingram on our panel. He is the Director of HR and Organizational Excellence at Ohio Valley Gas Corporation. It's one of our clients. And so he has real world experience with our True Codes program. I know I was at a business health coalition this week, and employers, you're always wanting solutions. You're always wanting to help drive your healthcare costs down. You're always wanting to take care of your people. And when we bring solutions to the table like this, the first question you have is, what is that going to mean for my members? What is it going to mean for their experience with their health insurance? And so that is why we are so excited Scott could join us today, because he's going to share his experience as an employer with this solution that we'll share more about with you today. So with that, we'll get down to the meat of the webinar, and Jacob will kick off with you. Let's start with the basics. Can you give us an overview of infusion medications and how they typically fit into a health plan?
Sure. Thanks, Adrienne. Nice to be with you all today. So, when we think about infusion medications, these are drugs that are given in a medical setting. They require that medical supervision and administration, oftentimes by an infusion nurse or other healthcare personnel, and can be given in various settings. So, that could be a hospital setting, or a medical office, or an outpatient infusion center setting, or sometimes even in a home infusion setting. But the key is that there's that medical personnel, that healthcare professional that has to administer the drug. And so where these fit into your all's benefit setup is that it's typically on the medical benefit. And so that interaction, that appointment in a medical setting, it's going to be billed to your medical insurance, so your TPA. And so in that bill, in that claim, they're also going to submit the cost of the medication as part of that claim. And so that could include the administration of the drug, any lab work, the professional fees, anything in there that could be associated or connected with um, the infusion of that drug.
Great. Thank you, Jacob. We know anything that happens in a hospital costs more, right? If you're in there and they give you Tylenol,
Mm.
there is, a ridiculous markup. So especially when you come to these specialty infusion drugs, they can be marked up quite a bit. It's coded in a lot of different ways. Sometimes it can feel like a game of Scrabble if you're looking at all the different ways that a J code can be billed. You have J codes, Q codes flying around. Jacob, can you help us make sense of that? I know people who are with us today may not be as familiar with how these are billed and making sense of that for them.
Sure. So when these medications are billed to the medical benefit, the drug itself is billed with a code that's called a J code or a Q code. You also might see an A or a C code that's submitted on that claim, but J and Q are the most common. And when a drug is billed with a J or a Q code, that's often marked up significantly. And so when you're thinking about a J or Q code, those are through the medical benefits. The equivalent code on our pharmacy benefit side is going to be an NDC, or National Drug Code. And so an NDC is billed with a very consistent cost when it comes to these infusion medications, but the J and Q codes are often marked up 200 or 300%. So using that relatable example you just mentioned with Tylenol, if you go to the ER with a migraine or a headache, you need a Tylenol pill. That's going to cost $10 probably, sometimes more, sometimes less, but for the sake of the example today, let's say $10. However, you can buy that whole bottle of Tylenol from Walgreens for $10. And so I'm not worried about the markup for Tylenol. It's just $10. We're not going to spend our time and focus on that. But when it's a $10,000 infusion that gets marked up to $20,000 or $30,000 a month, that's going to add up very quickly and impact the cost of your trend on your medical plan. And that's something we need to pay more close attention to. And so for these infusion medications that are very expensive, these can sometimes be in the range of 10, 20. There's even some that are 40 or $60,000. That cost can add up very quickly for our client.
Absolutely, 300 to 400%. And these are often hidden. These are hidden pharmacy costs that are on your plan, and they're hidden on the medical side. And so this is the type of innovation that Truex brings for our employer partners so that we can help them uncover these costs and provide solutions around that. I'm excited to get into the solutions here in just a minute, but Anna, there are more than 3.4 million patients receiving an infusion therapy each year. And sadly, that number is growing. I mean, that's already a huge number. Can you walk us through what kinds of conditions these treatments are covering and what the patient experience is typically like?
Sure. For our True Codes patients, we're looking at more the autoimmune, non-emergency type of diagnosis. They're typically chronic and ongoing, but it is something that is going to be scheduled. So we can deliver the medications ahead of time or know when their treatments are going to be ahead of time. So, for example, like some conditions would be MS or Crohn's, also to ulcerative colitis, asthma, psoriasis, those type of things. Again, they're not going to be anything that requires like an ER visit. We're not going to hold up care. The type of patients that we work with are going to be the ones that are on scheduled set infusion dates, so we can work ahead and see what type of patients we're going to be working with when we get a file sent to us.
So these are patients that aren't needing kind of acute care, but more chronic care that these are can be scheduled and we can intervene at that point.
Right. And these aren't something that are going to be based on like lab values or, like I said, an ER visit. These are ones that are set up. They're going to have infusions like maybe every 8 weeks, twice a year. It's a scheduled, controlled infusion that we know ahead of time what they're going to be infusing.
Great, thank you.
Mhm.
Infusion medications are pharmaceuticals like we've been talking about, but they're billed differently. Jacob, why is that? And how much are we talking about in terms of cost? I know you talked a little bit about that already, but
Sure.
why is it that they're billing on the medical side?
Sure. It has to do with how those facilities are used to submitting their claims. They're submitting the claim for the administration costs for that office visit. And so they're going to go ahead and bundle in that drug cost into that claim as well. I see a question in the chat. Do you find the markups to be higher for the drugs or for the facilities in which they are administered? And so the markup for that facility or for the administration cost could be present, but you're probably talking in the range of maybe couple $100 for that markup. And so then on the flip side, the markup for a drug, these drug costs, like I had mentioned earlier, are often in that $5,000 to $10,000 range, possibly even upwards of $40,000 or $60,000. And so putting our focus on those drug cost markups, going from a $40,000 up to an $80,000 infusion, is going to be a much higher impact to our clients than looking at those administration costs. The other piece of it is those reimbursement rates. And so these infusions can be given in a multitude of different settings. And so they could be given in a hospital or a home infusion or an outpatient infusion setting. And so we recognize that hospitals are often the highest markup for these medications. But as we think about that, I'm not so concerned about where they're getting it specifically, but rather, are we paying that fair price? Are we paying that accurate, reasonable cost for these specialty medications? Again, going back to that markup of 200 to 300%, I want to make sure that we're ensuring that they make a fair profit, not an obscenely high profit on these infusion medications.
Right.
Um,
Thank, yeah, thank you. Scott, so, as a PBM and as a PBM who's very much pharmacist led, so we have 1 in 10 of our employees is a pharmacist or some type of clinician like Anna, who's a nurse. We know what happens behind the scenes. As an employer, what made you take action? What was kind of the light bulb moment where you were saying, "Hey, I need a solution for this," and how did you make that decision?
So it was really pretty simple, dollars and cents. Um, so we have a self-funded health plan. Been involved with those for a number of years, long time. And with self-funded health plans, you tend to get for high claimants, especially if there's chronic conditions, um, the stop loss carrier puts in place lasers because they see that you're more than the average stop loss. And a couple of years ago, we had a team member's spouse has a chronic condition, and that stop loss or that laser for that particular individual was 850 grand a year
Mm.
that they carved out of the program, out of our coverage. So we started looking into it. As in my position, I'm also the HIPAA officer, so I can see all the data about people, which is a dangerous place to be, but it also is helpful. So we started looking into it, and what we found, I'll use some real life dollars that match up with what Jacob's talking about. This particular condition was a blood disorder that is chronic. It's not going away. So it's a long-standing issue we're going to have to deal with as long as we have this team member. We were getting charged $212,000 per treatment out of a reputable hospital here in Indiana. And that treatment took place every 8 weeks.
Wow.
So when we started to look into this, and I'm just going to say it this way, I'm an old sales guy also. So it's easy for salespeople to say something, but then dealing with the practicality of how it all works, sometimes they don't talk about. It was easy for them to talk to me about the program, but talking to our team member and getting them to, I respect doctors and what they do. And I appreciate that patients take what a doctor says as the gospel. I get it. My wife works in the hospital. She's a compliance officer. She's a nurse. But when it comes to dollars and cents, we basically called and explained, look, we can get this drug for much less money. You can have it done in an infusion center. We can talk to the hospital to see if they'll do it there at the hospital. They pushed back, of course, the hospital did, the doctor did, trying to claim that, he'd gotten special approval from Cleveland Clinic to do this here in Indiana and yada, yada. But the magic thing was when we went down this path with the team member, they quickly saw when I told them the dollars and cents, they're like, well, that doesn't make any sense to me. I said, no, it doesn't. So we now pay $67,000 a treatment. So that's over 300% markup.
Wow.
Once that claim went through for the first time, or we explained to the hospital why they weren't coming there for it anymore, magically, they reduced their number from 212 to about 82. Okay, that's still 15 grand more per treatment than what I'm paying for that treatment through True Rx and this program. So that's why I went into it. It was one big claim. Since that time, we do have, I think, we have like 5 people that are covered by our health plan that are in the program. So as far as the percentage, and we may talk about this later, but the irony is it's not like everybody has these, but if you just have 1 or 2, we have 140 people covered by 140 team members on the health plan. We have roughly 300 and some participants. So we have 5 people in the program. It's 1.5% of the people, but I just gave you the amount of money it's saving me a year, which impacts our business in a significant way, obviously.
Absolutely. And we hear these stories every day that a couple of members on a plan can really drive up your costs by 80%. So it sounded like we had the right solution at the right time. And I want to talk a little bit about what the True Codes program actually is and how that works. Jacob and Anna, I think you're tag teaming this one, but could you tell our attendees today, we've talked about what infusion drugs are, how expensive they are, how it impacted one of our employer partners. We have this solution called True Codes, but can we tell everybody what it is and what the experience is?
Sure. Thanks, Adrienne. So our True Codes program is our solution for these high-cost infusion medications. As a pharmacist, I feel somewhat responsible for being an expert on these medications. I'm the drug expert in this space. And so I want to make sure I'm supporting our clients and our broker partners and our consultants with solutions, with understanding of where they're spending their money, and make sure they're spending it responsibly. And so from the standpoint of a markup of over 300%, is there a way that we can get that cost down? Can we negotiate it? Can we shift the site of care from the medical benefit over to the pharmacy benefit? And the answer for many of these medications is absolutely yes. There's nothing to stop a medication from being billed on the medical benefits versus being on the pharmacy benefits. It's a drug, it has an NDC, and so it can absolutely come through the pharmacy benefits. With our True Codes program, just a little bit of information and background about this. In order to ensure this program is effective, we'll take those medications. We have a set list of drugs of about 50 to 60 J and Q codes that we've deemed as maintenance medications, non-emergency, not urgent medications that you'll need to go to the ER and get on an urgent basis. Rather, these are scheduled out several weeks for that infusion timeline. And so for these medications, we carve those out of the medical benefit. We have those excluded from the medical benefit and require patients to work through the pharmacy benefit. And so when we're thinking about what that patient experience will look like, I'll ask Anna to speak in a moment about what her team does. We have a team of nurse navigators here, like Anna and several others on her team that work hand in hand with the patient to ensure that they navigate this very complex healthcare system we have in the United States. If I had to do that myself, I would get lost, and I'm a pharmacist, so I can only imagine what our other patients, how they would respond and how they may struggle to navigate that. So very proud that Anna's on our team and can support our patients with that regard. So Anna, can you talk a little bit about how your team supports our patients as they shift over to the pharmacy benefit?
And
Sure.
Anna, I want to invite you to share a couple of patient stories. I love talking to Anna because she always has a story she can share. There's a lot of coordination that goes on behind the scenes that Anna and her team does. So yeah, would love to hear some of those as well.
Sure, absolutely. Before I get into the stories, our role as the nurse navigators with the True Codes program is to save the plan money, but that doesn't mean that we're going to decrease the care. And so we are not just a tagline. When you say health strategist, that's what our team is. So everyone that's on our team has over 15 years of experience. And you have to understand how to navigate this because it is very complicated. And sometimes a no in the beginning doesn't necessarily mean a no. We have different avenues that we can take, different questions we can ask, but we understand the process and we are truly part of that healthcare team. We're not just working with the insurance company, not just working for True Rx. We are part of the healthcare team. So we work with the ordering physician on what they would like for to happen with the patient and what we can work with the doctor. We work with the infusion centers. We work with the specialty pharmacy and we work with the patient. So we want to be the source of contact for all of those. So if anything comes up, they have a direct nurse that they are assigned to that they know they can call and we can work with them. So when we talk to the doctor's office and we talk about any changes, they don't have to do those changes. We're going to work on those changes. We're not giving anyone any extra work or anything that they have to do. That's very important to us because all of us that have worked in the infusion setting, the specialty infusion setting, understands that sometimes when there's a change of insurance as a nurse, your first thought may be like, okay, that's more work for me that I have to do. And they are relieved to know that we are a part of their team and they don't have to do anything extra. When we have a referral, we understand what information they need. We decrease calls to the ordering physician's office. And again, we're a health strategist with them. And we understand the questions that are going to be asked and how to take care of the patient. So all of us have different unique stories. I'll give you a couple, but most often than not, the patient often doesn't even really see that there's a change. More often than not, we just deliver the medication to where they're currently infusing, and they may not even notice any different at all. So that's typically what you're going to see. And again, you don't have that many patients that are affected. So it's not something that we send a mass letter out to everybody. It's something where we contact the patient individually and say, hey, listen, we're going to be working with you. We don't change our treatments. We work with their doctor. We're just there as a resource for them. But like I said, most often than not, they're really not going to notice a change. But when you have a unique situation, we do have some different stories that I can share. One of my patients was under her parents' insurance, and understandably so. When you talk about anyone that has a chronic diagnosis and they're getting a high-end treatment, everyone's really nervous. So we understand how to have those conversations because, again, we have worked in that setting, and we can build their confidence and let them know that we're there for them at any time. But in speaking with her parents, they weren't very happy, that they thought they were going to have a change. So we had to build up their confidence. And then when looking at the patient, she was actually in college traveling around for different internships. And in the past, she had to come home and do her infusions, and they were very frequent. So we worked with her, and wherever she was having her internship, we set up her treatment. We also found her options if those didn't work out and she was having a difficult week, if she wanted to infuse on a Saturday and Sunday. So sometimes when you work with independent infusion centers, you can have longer hours and more options. So we were able to follow her around on her internships. And so my first conversation with her father was not easy. And he ended up being our biggest advocate. He was very thrilled with everything. So we're used to those conversations. Another one kind of along the same lines that just happened with another one of our nurse navigators was another college situation where a member was having to come home to infuse, and she actually got the infusion. She was doing home infusion, got the infusion set up in her dorm room. So I don't know if I've ever come across that, but I will tell you, I have children in college, and sometimes when you have a medical condition, you have to come back home to your doctor. But she was doing home infusion, and this nurse found her an option for her to stay on her college campus and not have to come home. So people are usually willing to work with that and understand when you have to do those, but gosh, what a difference if you don't have to take the time and do that. So those are kind of some unique college situations, some that are a little bit not as exciting, or maybe not that big of a deal if you don't look at it, but we had an injection that was happening in a hospital, and we just simply deliver the medication to the same floor, just down a few rooms, and that's where the doctor's office was. And the patient didn't have to change addresses or anything. We just a few rooms down, and that saved the plan so much money. So it is important that you understand the processes and how these work and how we can save the patient money, but most important, not decrease their care, but to be part of their healthcare team.
Those are my favorite stories, that you can have cost savings, but you're actually improving the convenience of the patient to get their infusion. And to me, that is just remarkable. My husband had to have an infusion in a hospital setting, and he's in this big room with tons of people getting infusions that day, and really sick people. And sometimes Anna and her team will go out and visit these infusion centers on their own to make sure that the quality of care is the same, or not, if not better. A lot of times it's better. It's a better experience for the patient. So I think that's probably one of the things I love most about this program. Scott, you dealt with an employer too, maybe, on your plan. What was their experience like?
So I want to echo what Anna was just talking about. As I kind of said up front, I was a little nervous in implementing it because you are changing someone's treatment. This is obviously a life-supporting drug that they're getting, and you don't want to mess with that. What I will tell you is that my interactions with True Rx and True Rx's interactions with our team members and their family have been exemplary. I'm not just saying this. I've been in the business world for 40 years. I have never had a vendor or a partner that is as responsive and helpful as True Rx is. I'm not getting paid to say that, other than the fact that it saved me a bunch of money. But when we changed, I'm going to go a little off here and I'll come back. We've been with it. We were with a different PBM. When we made that change, True Rx stepped up on January 1st and January 2nd and had drugs delivered to those patients within 24 hours, where the previous PBM had dropped the ball at the end of the plan year. So the customer service is off the charts as far as I'm concerned. They have those conversations that Anna's talking about. I don't have to be involved. We don't have to be involved. It is a very personal, it's like another caregiver that True Rx is providing. And our team members have had nothing but positive things to say about the whole experience. I just dealt with one again yesterday, someone new, and the response time, it was less than 24 hours from the time the problem was brought to my attention with a new drug, and it's now taken care of and being prescribed and being delivered today. I kind of looked at the question and answer, so I want to kind of address some of those questions from my side. I won't use names of carriers or TPAs. I don't want to do that to them. I will say that I went to a carrier, to a network that I personally cannot stand. I went to them because they're the big boy with the big stick, and in this business, to control healthcare, that's what you do. But as a self-funded plan, I made it very clear to them, or to my broker, that if we're going to go there, I need to have certain levels of control. They didn't want me to carve out the PBM. They've got their own. They've got their own that they're doing, spending incredible money to market to everybody, including myself. But carving it out to True Rx was one of the conditions we made.
Good for you.
I still have to go through them before I can do something, especially in this realm, because we are moving something from medical over to the RX side. But it just is what it is now. If they want my business, this is the way it's going to be. So to the questions about, can you get this stuff carved out? Yes, you can, if you play a little bit of hardball and it's more than worth it. But again, I can't say enough about the service that my team members are getting from this program. They're getting care. The reality is, and I think Jacob talked about it early on, when something's first diagnosed or first happens, yes, that first infusion is going to happen in the hospital setting. But after that, in most cases, there's no reason why they can't be involved in this program and either do it. I mean, Anna laid it out. I'm not quite sure. I think one of ours is still done in the hospital setting. I'm not positive of that. But from our standpoint, the savings we were going to make, we were going to pay to transport our team member to the closest infusion center instead of them, and it was going to be closer than where they were traveling to the hospital, but I was willing to pay that. Now, they didn't take me up on that because for them, it was half the drive time to get to the infusion center where they're now getting that done compared to the hospital they were driving to before. So there's multiple benefits here, and you guys have done an awesome job of taking care of our team members, which is what my job is. So you're just an extension of what my job is. And I can't say enough good things.
Scott, be careful. We're going to ask you to join our marketing team. But, it's really hard to, express to people that the experience at Truex is different and it is intentional. This is not something, we have an awesome team who really care about patients, but it is an intentional focus of our company. A third of our company is dedicated to the experience that people have from our clients like you, from the patients, your employees that you care about. We have a team dedicated to our patients. We have a team dedicated to our specialty patients who are on specialty medications, who are the sickest people on your plan. We have a whole team dedicated to them. And we have a team dedicated nurses for the True Codes program. So the experience you speak about is very intentional at Truex. It is why we're different. And it's, for us, savings are great, and we will go after every savings that we can. But that patient experience is everything to us, and it's a huge focal point for Truex. So thank you for the nice compliments. Thank you for being our client and trusting us. We know that's not easy, and especially after you've been through the ringer. So we have several questions that have come in. I'm going to jump to those if you
If
all don't
if I
mind.
can, I'll go ahead and jump because I did see one that I can answer for him, so they
Sure.
can come out of my mouth. And I kind of related it earlier. So our particular health plan, we offer two different high deductible health plans. I've always had the pharmacy embedded within the plan. I've hated it when they were not. It's just not, it's just better for everything to be embedded. So our current plans are embedded, but we have carved the PBM out and it still gets managed so that having your RX plan embedded within your overall health plan is not a stop to being able to do this. That's part of what we do. So that hopefully that answers David's question that he put forth about the whole embedded piece.
Great. Scott, I love that you're jumping in. This is fantastic.
Mhm.
All right. Do you find, so the first question here is, do you find markups to be higher for the drugs or for the facilities in which they are administered?
I'll take that one, Adrian. I would say that it's absolutely going to be the drug side. You're talking about an infusion drug that's going to be $10,000, sometimes much more expensive than that, versus the infusion costs, which are going to be in that hundreds of dollars range. And so even if that infusion cost gets marked up, you're not talking about the markup that would be associated with the drug costs. And so it's absolutely going to be the drug cost in these situations.
Great.
I would say on that, that typically your infusion costs are typically more in a hospital, but that's not your big, like Jacob was saying, that's not your big driving cost, but those fees are also typically more.
There are several, and these are probably experienced brokers who are writing these questions or employers who have been dealing with this. Several questions have come in about, having the ability to play ball with our medical partners to administer this program, to make this program work. So, first question here about that is insurance companies typically only cover infusion medications under their medical policies, thus the need for claims to be filled as such, correct? Question mark. So I think they're asking, it's on the medical side. So how do we get it to the pharmacy side?
Sure. So these are drugs. So again, these are going to have NDCs, and there's nothing that's preventing those drugs from coming through your PBM True Rx. We can fill those at a pharmacy, and oftentimes that pharmacy is going to ship those to the medical offices via white bagging to do the infusion in the medical setting. If that medical setting, let's say it's a hospital that has their own pharmacy, and they want to bill for that medication within their health system, that's fine too. The key is that we want to ensure our clients and our patients are getting that fair cost, that reasonable cost, and not having that markup that we've been referring to on these medications.
On that line, Jacob, as you're dealing with healthcare systems, and that's a big question here. Um, do you ever work with any that don't allow brown bagging or citing that quality and liability of bringing in from Trurex is from outside source? Is that ever an issue?
Sure. So when we're talking about brown bagging, that's going to be where the medication gets shipped to the patient, and then the patient brings that medication into the medical facility. Our program does not do that because many of these drugs often have to be refrigerated and have very special handling. And just from a liability standpoint, I respect that. Infusion centers will not infuse those medications out of risk of harm to the patient. And so our program does not support brown bagging. Rather, it would get shipped straight to the facility. Along the same lines, there are some facilities that may refuse to accept that delivery from a pharmacy. And usually when I run into that, those facilities are looking out for their own bottom line. They're used to billing these medications through the medical insurance and getting that extra profit. But like Scott had said, when we find those alternative sources, it really forces them to play ball. forces them to come to the table with that better price. And so that's going to be where our True Codes program comes into play.
And I
Thank
will
you.
add from my previous experience with our previous PBM, they pushed, it was more of a brown bag issue as opposed to, I like Jacob calling it a white bag issue, because that is the difference. I wholeheartedly agree because I've got a different team member. They'd had kidney transplant, so there's certain things that they have to have all the time, and they're delivered straight to them. They can take it home. But to try to get around, yes, that's not what this is. True Rx will deal directly with the facility, whether it be an infusion center or the hospital, et cetera. And to further, I know it's been answered, but the reality is, to drive home, this is all on the drug side where for most all the markup is. The hospital is bound by certain guidelines of what they can charge for the actual service and their admin. So they can only mark that up so much. The drug is the part where they can mark it up whatever they want until there's pushback.
Speaking of pushback, do networks push back moving J codes over to the PBM? How do you get around the BUCA networks, the Blue Cross, Blue Shield, United Healthcare, those types of players? Now, we have United Healthcare on several of our our True Codes clients. There are several BUCAs that do work with us on this program, but Jacob and Anna, any comments there about perhaps finding the right TPA partner that will help navigate or help partner with us on this program?
Sure.
And do we have to
Yeah.
get pushback?
Yeah, absolutely we do. And so from the standpoint of, is there opportunity for cost savings? And so when we have a medical claims file, our team is able to provide that cost analysis and give you insights to where you're spending your money on these infusion medications. And so if there's a high cost savings, we're going to inform you of that and work with you and your TPA to determine, is this a program that we can implement? Unfortunately, the reality is I have run into situations, TPAs that say they are not willing, or they're not able, or maybe they don't have the system set up and support in order to carve these medications out and do so on a consistent, reliable, accurate basis. And so at that point, it becomes a decision point with the client and the TPA. Is that something that is worthwhile and you need to pursue? If there's no cost savings, it might be something where we set a calendar reminder, let's check back in 6 months or a year. But in the case of Scott, you heard his testimony this morning about how the cost savings just called for that implementation. And so it was a change that they needed to make as an employer to ensure that their health plan stayed viable. And so from that financial standpoint, yes, TPAs sometimes are reluctant or just flat out will refuse. But we work closely with them, talk them through what the program setup is, and then back that up with our nurse navigators to ensure a very smooth patient experience.
And we're happy to consult with any of you on the call today that are wondering if, your current medical partner would help, be supportive of this program. And we're happy to walk that through. But it sounds like there are some employer groups on here ready to take action, like Scott. They're asking, about what reporting should they be asking for from both the medical administrator and the incumbent PBM. For them to do some kind of cost analysis for their current claims.
I would say you may be familiar with those infusion claims that are coming through your medical benefits. You might see that show up on a top claimant report, but our team is ready to do a full analysis for you. So what we would request is a 12-month report of those J and Q code claims. When we get that report, we're going to look at those high cost claims and look to see, is there a utilizer of one of those 50 to 60 meds that we've identified as part of our True Codes program. So again, we're not looking for those emergency drugs given in the ER. Rather, these are scheduled infusions that we're going to be able to work ahead and ensure a smooth transition to the pharmacy benefits. Along with that analysis, we'll show you what that markup is currently. Sometimes it's going to be in that 200 to 300% range, but it varies widely. You could have I've seen two different patients taking the same drug. One could be at $15,000. The other could be at $45,000. And so that's not unreasonable to see for the same medication, for the same dose on the same plan. That type of cost variability is very common on the medical benefits. So we're going to personalize that cost analysis to your individual claims.
Great. Thank you, Jacob. We have a current employer that's one of our clients, and they're asking if they wanted to implement this program now, do they have to wait till renewal to do that? And you don't. We can turn on this program at any point. So we're happy to do that for you. And if you'll reach out to your account manager, or I'm sure there will be contact information shared after this call, we would be happy to do that for you. So thank you for that question.
I did want to, I thought I'd jump in, sorry.
Sure. Sure.
To the question about network, I guess I will say the name. You mentioned some other names. Anthem is that provider that we went to that I don't necessarily care for, but they're a big boy. And needless to say, they own a number of the Blue Cross Blue Shield networks across the country. So you can play with them. You just have to push.
Yeah. And I love, Scott, that as an employer, you are your best advocate. You did not take no for an answer. You are pushing for what you need. And I do recommend that same kind of approach for all employers. You have to be the ones in control of your costs and ask for what you need, ask for what you want. A lot of people just, they get the bill and here's your 6% annual markup, and they think that's how much healthcare costs, and they'll walk away. So it's great that you have been an advocate for yourself as an employer, but also for your members.
Well, and I guess we talked a little bit about this off, but in the world I live in now, so Ohio Valley Gas is a regulated utility. That means that all of the people we serve are paying our bill. We go in the way utilities work, as I'm sure everybody's aware, and I'm sure you don't like it when you get the notice that your utility wants to up the rates. But the way it works is we do a rate case, we show what our expenses are, we show what our compensation is for things, we have to justify all of that, and then we get rates based on those, and then we live under those rates for X number of years. We're locked in at those numbers, and as costs continue to go up, we have to deal with that. Our most recent rate case, the biggest reason we went in was the rising cost of healthcare. Our costs had gone up 8 times what we had in the rate case. So I was one of the key witnesses, and I basically had to demonstrate to the Regulatory Commission in the state of Indiana, what had I done to try to control healthcare costs that we were now going to be passing on to our customers. And this was part of the story, and they accepted our number without pushback because I could demonstrate the different things we had tried to do to control health costs. So this is a real game changer.
Your healthcare costs was the reason why you had to change your rates. I'm sure many employers on this call right now relate to that very same story. Well, that's why we're here to help. We're here to be health strategists, as Anna said. So really appreciate that insight, Scott. I want to just get to some more of these questions. So we'll hit on some easy ones here. Is there a cost to utilize the True Codes program, or is this available to all employers groups who have True Rx as their PBM? Jacob, you want to take that one?
Sure. So this program is available to all of our True Rx clients. If you opt into the program, even if there's not an impacted patient, it serves as a great proactive solution. Our standard fee for the program is based on a percentage of cost savings. So 20% of the shared savings is the program fee for it. But there is a program fee cap. And so in the case of Scott's patient, that cap certainly came into play. So we're not charging 20% of that cost savings every 8 weeks. Rather, it's going to be capped at $2,500 every 4 weeks. And so that's our standard fee for the program.
Great. Next question. Will you explain how the administration costs are covered for an IV medication, infused medication, if the medication is going through the pharmacy benefit instead of the medical benefit?
That's a great question.
Mhm.
So those administration costs, those infusion costs still are often billed through the medical benefits. There are a handful of different clinics that we have worked out that direct arrangement with, just to ensure easier access to those clinics. But there's not a network of infusion centers that you're required to use or participate in with our True Codes program. Rather, it's going to be personalized to that individual patient. And so Anna and her team, they're going to work to find a site that the patient is convenient to the patient. So if that's the same site that they're already infusing at, great. That's where the majority of our patients end up. But there are going to be some patients that say, well, that is a pretty far away from where I work. It'd be great if it could be closer to home or something like that. And so in those cases, Anna and her team will work with the patient, find those alternative sites, and vet them from a clinical perspective. Are they going to provide a quality infusion for my patients? They're going to ask questions about the tubing and the training and many other things that are over my head as a pharmacist. But I've attended some of those calls and I've seen Anna get off of the line and say, I don't think they would do a good job. They may still mention it to the patient because it's up to the patient ultimately, but they'll give that recommendation to the patient. I don't think this is a good idea for you. And so just that personalized care of not just trying to check the box and find some place to go because we know there's going to be savings. Rather, the patient care is at the center of everything this program's about.
Yeah, and I would also like to add, besides working with the patient in the infusion centers, is we also very often work with the ordering physician. If for some reason the patient wants to move or we have to move the patient, we work with the ordering physician. And sometimes it's not even a matter of what do you recommend? Sometimes it's a matter of where is there someplace you don't want them to go? So we do work with those ordering physicians and see what's best for the patient. And our company has allowed us to go on site and visually check out and vet all these, infusion centers that we will be working with. And then again, like Jacob said, we know the questions to ask. If I call somewhere and they can't give me an average of how many Remicades do you do a week, I'm moving on because you aren't versed in that type of infusion and it's not going to work out. So we know the questions to ask. And again, our job is to save you money. But as nurse navigators, we're advocates for the patient. So if we just save money and send them somewhere that's not going to work, it's going to not bode well for the long run. So we do take an extreme amount of time to work and individualize each patient's care. And also, like Jacob said, sometimes we assume they want to be closer to their home address, and we can be like, oh, I've got some place that's 10 minutes away from you. And like Jacob said, sometimes patients will say, listen, while I'm out, I want to be closer to my work and infuse there. So we do let them be a part of that process, and we don't dictate where people have to infuse. It's a collaborative effort.
Mhm. I think that's what I love most about that program is just the amount of effort that you guys put into finding not just the infusion center that's going to save money, but the right one for the patient. So that's so well said. I want to get to a different type of question about rebates, which is, a huge piece of the pharmacy economics. So I think it's a great question. When you move the medication from the medical to the pharmacy benefit, is there a rebate for these drugs? And if so, who gets it?
Great question.
Mhm.
TrueRx, we are a transparent PBM. And so any rebates that we get, we do pass back to our clients. And so it's not a source of revenue for our PBM. And so we make our money off of those admin fees. And with this program, that program fee that we talked about, not all of these drugs get a rebate though. So if we do get one, of course, we'll pass it back. But I will say that not all of these will have a rebate on them.
Great.
And I would say as part of the True Codes team, that is part of our job after we get a patient is to see if there's any other cost savings that we could implement for that patient.
And
Great.
I guess if I can jump in from the
Please.
employer side, yes, I get rebate checks. I've always gotten rebate checks from a previous PBM. What I will say is this, I get less in rebate checks now than I did when I was with the previous PBM, but I'm spending a lot less money. So I'll take less in rebates because total dollars, I'm way ahead.
That is an excellent lesson, Scott. I think, I think just we've been educated to lower your costs through higher rebates. That's how a lot of the big three PBMs sell themselves. That's what they put on their spreadsheets as they're showing you what the best option is for you. So I think it's very wise to look at your overall cost and not just your rebate line. So great advice to our employer groups. I cannot believe we are running out of time. We have about 4 minutes left. We have several questions left. There have been a few questions about, will we carve out this service for, if you're an employer group who has another PBM that you're happy with, and we're so happy to hear when that happens. If you guys could use the True Codes program with your current PBM. Today, we don't offer that service. We do get asked that quite a bit because we have a lot of in-house solutions that we provide to our clients. But today, those are reserved for the True Rx clients. But we'll be sure to let you know if that were to change. So thank you for that question. I do want to wrap up just because this has been such a great conversation. We have, another webinar coming up and want to be sure that we have an opportunity to talk about that as well. But again, we are True Rx. We are here to be your health strategists. We do that in many ways, from our solutions to our patient care, but these webinars and this education is part of that. We want to be thought leaders for employers, for brokers, for people who want to learn more about the pharmacy space. That's what we're here for. I want to thank our panelists today. I think everyone will probably agree this has been one of our better webinar series. And I think, Scott, you added a lot to the conversation as an employer. We can go out and tout our great patient care and we're going to save you a bunch of money, but to have someone who's actually experienced that, it goes a really long way. So Scott, we thank you so much for being here. Anna, our nurse navigator, there's no one better to talk about this process than someone who does it every day. Jacob, our director of clinical strategy, you can see why he has that position and does a fantastic job about that. You've heard some impressive results today, but I encourage you to also visit our website. There's a blog about it. We were celebrating our 5-year anniversary with our True Codes program. So this is a program that we have been doing for several years now. The recording of this webinar will be available on our website. So if you had to jump off or if you want to pass this along to someone you know that might benefit it, please do that. We're here to be thought leaders. If you would like to learn more about True Rx to be your PBM or one of our programs, please do not hesitate to reach out to us. And we look forward to seeing you at our next True Conversations next quarter. So thank you all for being here. We had one of the highest attendance for our webinar today. So we thank you all for spending your time with us, an hour with True Rx, and have a great summer. We'll see you soon.